Thank you for the opportunity to present our study. None of the authors have any relevant disclosures. Diaphragmatic hernias represent a spectrum of diseases from small sliding hiatal hernias to large symptomatic paraesophageal hernias. Traditionally, repair of these hernias was performed in an open fashion, either transabdominally or transthoracically. However, laparoscopic repair of these hernias has shown improved perioperative outcomes and is now the preferred approach in most cases. Two previous studies have evaluated the relationship between hospital volume and outcomes in Nissen fundoplication for GERD and Heller myotomy for achalasia. However, laparoscopic diaphragmatic hernia repair is a more complex operation associated with a greater risk of morbidity. There are no current studies evaluating the relationship of hospital volume specifically on the outcomes of laparoscopic diaphragmatic hernia repair. Our objective was to evaluate the effects of hospital volume on outcomes in patients who underwent laparoscopic diaphragmatic hernia repair using a large national database. Our hypothesis was that increased hospital volumes was associated with improved perioperative outcomes. Thank you. We performed a retrospective review of the 2008 to 2012 NIS databases. Patients with a diagnosis of diaphragmatic hernia undergoing elective laparoscopic diaphragmatic hernia repair and/or Nissen fundoplication were included. We excluded all pediatric, emergent, and open cases. Our primary endpoint was to evaluate the risks predictive of in-hospital mortality. Our secondary endpoints were to evaluate in-hospital mortality, serious morbidity, and length of stay based on hospital volume. In order to do so, we performed a multivariate logistic regression analysis to identify risk factors for in-hospital mortality. Included in our regression model was age, gender, incremental increase in hospital volume of 10 cases per year, and patient comorbidities. We used univariate analysis to evaluate secondary endpoints. 31,000 cases met the inclusion criteria. We found an overall in-hospital mortality rate of 0.14%. This table shows the risk factors we identified for in-hospital mortality. The risk factors are listed in the far left column with the adjusted odds ratio and mean difference in the middle and the p-value to the far right. Renal failure, age greater than 60, and congestive heart failure were associated with increased hospital mortality. Increasing hospital volume and diabetes were associated with reduced in-hospital mortality. We wanted to evaluate the probability of mortality versus volume using our model. This graph shows volume on the x-axis and predicted mortality per 1,000 cases on the y-axis. As you can see, an increase in 50 cases per year reduced the in-hospital mortality by almost 50%. This graph shows the actual plotted in-hospital mortality for per case volume. Again, volume is on the x-axis and deaths per year on the y-axis. Most hospitals reported 0 annual deaths, as represented by the red line. Of those reporting in-hospital mortality, there was an inverse relationship between increasing volume and hospital mortality, with a threshold around 10 cases per year. Using the number of 10 as our cutoff, we defined low-volume hospitals as hospitals performing less than or equal to 10 cases per year, and high-volume hospitals performing more than 10 cases per year. The majority of cases, about 75%, were performed at high-volume hospitals. This table shows the patient characteristics and comorbidities according to hospital volume. The comorbidities are on the left, low-volume hospitals in the middle, and high-volume hospitals to the far right. Low-volume hospitals had older patients with a mean age of 56 years. High-volume hospitals had a mean age of 52 years. Low-volume hospitals had more male patients and higher rates of chronic pulmonary disease. High-volume hospitals had higher rates of diabetes, hypertension, and liver disease amongst their patients. This table shows the outcomes by hospital volume. Again, the outcomes are listed on the far left. In-hospital mortality was almost double for low-volume hospitals compared to high-volume hospitals, and low-volume hospitals also had an increased mean length of stay. There was no difference in serious morbidity between either of the two hospital groups. We then evaluated the individual complications that made up serious morbidity by hospital volume. Low-volume hospitals had higher rates of postoperative pneumonia, respiratory failure, and sepsis. High-volume hospitals had higher rates of GI complications. There were several limitations to our study. This is a retrospective review of an administrative database, so it is subject to coding errors, particularly when it comes to coding complications. The NIS only evaluates inpatient deaths, so we may underestimate the true mortality rate for this procedure. We're unable to determine the size and type of hernia, which may be important risk factors, and we're unable to determine specific surgeon volume within each hospital. In conclusion, the overall in-hospital mortality for laparoscopic diaphragmatic hernia repair is low at 0.14%. High-volume hospitals had almost half the inpatient mortality when compared to low-volume hospitals, but had similar rates of serious morbidity. The most important risk factors for inpatient mortality were renal failure, age greater than 60, and congestive heart failure. We identified an inverse relationship between hospital volume and mortality, and an increase in 10 cases per year was associated with a 10% lower adjusted odds of in-hospital mortality. Thank you.